This lecture covers musculoskeletal autoimmune conditions. The first disorder that we're going to look at is rheumatoid arthritis. Rheumatoid arthritis is a chronic systemic autoimmune disease that involves inflammation of the connective tissue in the synovial joints. It's believed that there is a combination of genetics and environmental triggers that can set off rheumatoid arthritis occurring in an individual. Characteristics of rheumatoid arthritis consist of the patient going through periods of remission and exacerbation for many years to come. Incidence increases as a person gets older and peaks between the ages of 30 and 50 years of age. Many patients with rheumatoid arthritis may report a history of a precipitating event, such as an infection, stress, exertion, possibly recent childbirth, or a surgical procedure. However, in several cases, rheumatoid arthritis is typically considered insidious, meaning we are not sure why it occurred in that particular individual. Manifestations of rheumatoid arthritis include the patient reporting joint stiffness after being inactive, such as morning stiffness of the joints that lasts 60 minutes at least to several hours or sometimes even longer as the disease progresses. One characteristic of the disease is that the symptoms do occur symmetrically, meaning if the joints of the hand are affected on one side, the joints of the hand will be affected on the other side as well. This is in contrast to osteoarthritis, where only the joints that are used are affected. So osteoarthritis has asymmetrical joint involvement. Rheumatoid arthritis has symmetrical joint involvement. It does most often affect the small joints, for example, of the fingers and the hand. However, it can affect larger joints, and at times even the cervical spine may be involved. Patients will report joints that are tender, painful, and warm to the touch. Pain is increased with movement of the joints. Also, it can be noted on assessment that deformities are often present. The image on your slide demonstrates some of the different types of deformities that may be present in late-stage rheumatoid arthritis. These are often consistent with what we associate as far as deformities with rheumatoid arthritis go. Ulnar deviation and swan neck deformities are two of the most common joint deformities that we see of the fingers. Spindle-shaped fingers and joint enlargement are also often noted on assessment of the hands. Some other symptoms that the patient might report is muscle weakness, having difficulty walking. They may experience paresthesia of their hands and feet. And as the disease progresses, they may experience muscle contractures and muscle atrophy. Diagnosis of rheumatoid arthritis consists of a collection of multiple different types of laboratory tests. Rheumatoid factor, the erythrocyte sedimentation rate, a C-reactive protein are all going to be used to look for signs of inflammation and signs of an autoimmune disease. In addition, the anti-nuclear antibody is also going to be another test that can be done to look for evidence of an autoimmune disorder, as well as the anti-citrullinated protein antibody, which is also going to be used to look for the presence of an autoimmune disorder. Synovial fluid analysis, x-rays of the joints, and bone scans may also be part of a collaborative diagnostic testing process to rule in the diagnosis of rheumatoid arthritis. As far as the care of the patient with rheumatoid arthritis, pharmacological therapy is going to be one of the main approaches. This is going to involve the use of DMARDs, disease-modifying anti-rheumatic drugs. These drugs are meant to decrease the permanent effects of rheumatoid arthritis. Some of the most common drugs used in this category are methotrexate, sulfasalazine, hydroxychloroquine, and leflunomide. These drugs are all discussed in your ATI Pharm Made Easy module covering the treatment of rheumatoid arthritis, and you do need to make sure that you review them in preparation for the exam. Corticosteroid therapy also may be used at times. This can be either low oral dose therapy for short periods of time during periods of exacerbation. They will not want to keep the patient on long-term corticosteroids. They also may use the intra-articular injections as part of the treatment plan during periods of exacerbation for the patient. NSAIDs and salicylates are another option that can be used on a long-term basis in patients with rheumatoid arthritis. However, in contrast to the normal administration of an NSAID, where we may take it for a headache and expect relief in 45 minutes to an hour, if an NSAID therapy is being utilized as part of a rheumatoid arthritis protocol, the patient has to be taught that it can actually take 2 to 3 weeks for them to notice a full effectiveness of the NSAID therapy. They're not going to notice instantaneous relief from those medications with this particular disease process. Some non-pharmacological measures are to utilize therapeutic heat and cold as desired to make sure that the patient gets adequate rest. Physical therapy and occupational therapy should be involved in their plan of care. And specifically speaking about, their rest periods and their mornings, where the morning stiffness is usually quite significant, it could be important to adjust the patient's daily routine or plan their care around the fact that we recognize that they do have that morning stiffness. So they may need a little more help with their ADLs in the morning than they do later in the day. The next autoimmune disease that we're going to look at in the musculoskeletal system is systemic lupus erythematosus, otherwise just known as lupus or SLE. This is a chronic multi-system inflammatory autoimmune disease that is characterized by an unpredictable course with alternating periods of exacerbation and remission. It is most commonly occurring in women of their childbearing years and more common in African Americans, Asian Americans, Hispanics, and Native Americans. This disease process ranges anywhere from a mild disorder to a rapidly progressive disease that can affect many organ systems. The image on your slide gives an indication of all of the different body systems and how that particular body system is affected by lupus. I'm going to just touch on a couple of symptoms from some of the various body systems, but it is important that you take the time and review this comprehensive list of symptomatic presentation that can occur in association with lupus. So I'm not going to read over all of them to you during the lecture, but I want you to take the time to be familiar with what types of problems we can see in each of the different body systems in relation to lupus. So some of the symptoms that I'm going to point out to you are, in the musculoskeletal system, polyarthralgia is a very common problem. That refers to pain in multiple joints. Morning stiffness, just like I referred to a minute ago with the rheumatoid arthritis, is also something that the patient experiences. In addition, we can see the swan neck finger and the ulnar deviation deformities develop over time with lupus, just as with rheumatoid arthritis. When it comes to the dermatologic system, it is common to see, especially in sun-exposed areas, that we see vascular lesions present on the surface of the skin. Oral and nasopharyngeal ulcers are also fairly common in up to 30% of cases of lupus. In addition to that, mucosal ulcers also often can be present. And a butterfly rash occurs in half or more of patients diagnosed with lupus. The butterfly rash is present across the bridge of the nose and the cheeks. This is a pretty significant symptom that is oftentimes associated as a characteristic sign of lupus. Raynaud's phenomenon is a common cardiopulmonary symptom that patients with lupus report. Raynaud's phenomenon should have been discussed back in your cardiac course. If you're not familiar with that, I encourage you to go back and look up Raynaud's phenomenon to recall what that particular disorder looks like. But it is where we see capillary spasms in the hands that cause the fingertips to change from white to blue to red. Patients with lupus frequently report the presence of Raynaud's phenomenon. As far as the nervous system goes, seizures can eventually be present, and in some patients, eventually cognitive dysfunction, such as memory deficits and disorientation, may occur over time. The last body system that I'm going to touch on is the renal system. The renal system does become one of the most problematic body systems with lupus. Managing the disease and slowing the progression of the disease to keep it from damaging the renal system becomes one of the primary goals of treatment in lupus patients. This is because within 2 years of diagnosis, over 75% of lupus patients have some level of renal disease or renal damage. Because this is such a prominent problem in the lupus patient, it is important that there is ongoing assessment of lupus patients for any indication of renal damage or renal disease developing. And if that is noted, it has to be treated promptly to minimize the long-term impact on the renal system. Lupus is a disease that is diagnosed by exclusion, as many of our autoimmune diseases are. Diagnosis can be rather difficult to achieve, and it's primarily done based on the criteria that relates to the patient's history, the patient's physical exam, and some laboratory findings. In addition to several other laboratory tests that will likely be done, the anti-DNA antibody test and the ANA titer are two of the most significant laboratory tests done to support a diagnosis of lupus. The anti-DNA antibody test is considered one of the most likely markers to indicate that the patient does have lupus. These two tests are positive in almost all patients with lupus disease. Because there is no specific test for lupus, the American College of Rheumatology has established an official list of 11 criteria that is used to classify a diagnosis of possible systemic lupus. The presence of at least 4 of the criteria are necessary to lead to the lupus diagnosis. The criteria consist of a combination of several different significant body system symptoms in addition to the laboratory testing that I mentioned already. An example of some of the symptoms included in the criteria are that butterfly rash that spreads across the cheeks and the nose, the photosensitivity or those cutaneous lesions that occur as a reaction to sunlight, the presence of mouth or nose ulcers, the reports of arthritis in at least 2 or more joints, along with some tenderness and swelling, any sign of renal disease, such as excessive protein in the urine or cellular cast on a urinalysis exam. These are all examples of diagnostic criteria. As I mentioned, you don't have to know all 11 criteria, but just understanding that it takes at least 4 of the 11 criteria to be present in order to support that diagnosis for the physician to determine that it is most likely lupus. Early diagnosis and effective treatment is crucial to survival in the lupus patient. Survival is also influenced by the patient's age, their race, their gender, even their socioeconomic status, any other comorbidities, and the severity of their lupus disease. Treatment is going to consist of a combination of different types of drug therapy, such as NSAIDs for the mild polyarthralgia or arthritis. Oftentimes, then the DMARDs or the anti-malarial drugs, just another term for that, is the hydroxychloroquine. They're going to use this because this is a great drug for lupus patients. It modifies the immune system, but it does not suppress it. Hydroxychloroquine reduces the occurrence of flare-ups. And again, hydroxychloroquine is referred to as an anti-malarial, but it's also referred to as a DMARD. So some of these drugs actually cross drug classifications. I'm not trying to confuse you, just wanting you to understand that Many drugs used in the treatment of autoimmune disorders can fall under a couple of different drug classifications. Steroid-sparing drugs is also another, again, just another group of drugs that can still refer to those DMARDs, those disease-modifying antirheumatic drugs. And the one that we're really looking at here, again, is methotrexate. Methotrexate is going to be preferred to manage the mild flare-ups and the pain, and patients are oftentimes going to be on the methotrexate long-term, as well as the hydroxychloroquine long-term. Corticosteroids, as I've mentioned before, we're going to limit the use of those in autoimmune disease patients. We're only going to use those in periods of exacerbation or severe flare-ups. Ongoing assessment with the lupus patient is important to assess the patient's physical, psychological, and sociocultural problems in conjunction with the long-term management of their lupus. Supportive therapy becomes very important in seeing how the patient is able to cope. Counseling may be necessary. Physical effects of the disease sometimes can lead to isolation, self-esteem issues, and body image disturbances. So those need to be monitored for and addressed if they occur. We want to assist the patient in developing realistic goals. We want them to get regular exercise, but also at the same time conserve their energy when needed, to learn to pace themselves, and it's very important that they avoid physical overexertion. We also want them to learn to avoid physical and emotional stressors when at all possible. If the patient is of childbearing age and pregnancy is a possibility, they should be counseled in regards to the possibility of becoming pregnant. In most cases, women with serious lupus should be counseled against pregnancy, as it's likely to exacerbate their condition even more. It's also notable to discuss with the patient that lupus can cause infertility. Our last disorder to discuss in the autoimmune diseases is scleroderma. There are two different types of scleroderma. One is known as limited cutaneous scleroderma. This is the most common and accounts for about 80% of scleroderma patients. And this is when the skin only is affected. Diffuse scleroderma, on the other hand, is when both the skin and the internal organs are affected by this disease process. So scleroderma is a disorder of the connective tissue in which the connective tissues of either just the skin or the skin and the internal organs become sclerosed or hardened. In other words, they lose their elasticity. The exact cause of this is unknown, but it is believed to be an immunologic dysfunction that plays a role in tricking the immune system into attacking the skin and or the internal organs. The manifestations of scleroderma are identified in the acronym known as CREST. So the C stands for calcinosis, which is the painful calcium deposits that can occur in the skin. Raynaud's phenomenon, the abnormal blood flow to the fingertips, is the R. The E stands for esophageal dysfunction, which is the difficulty swallowing that can occur as a result of the stiffening or the sclerosing of the esophagus. Sclerodactyly is the tightening of the skin that occurs and is most notable on the fingers and toes. And telangiectasia is the T, and this is when there is dilation of the capillaries on the face, hands, the forearms, and the palms that actually cause small red spots to appear over all of these areas. There's no treatment for scleroderma, and it's the only thing that we can do, or excuse me, there's no cure for scleroderma, and the only thing we can do is to provide supportive treatment such as physical therapy and occupational therapy, and encourage range of motion to keep the joints moving and to keep the extremities moving as long as possible. We can also teach them to avoid the triggers of Raynaud's phenomenon, such as avoiding stress, cold, avoiding vasoconstrictors, and not having any finger sticks done. Although there is no specific drug therapy or treatment regimen that is directly done for the disease process itself, There are some drugs that can be utilized for the symptoms or the problems that scleroderma creates. One is calcium channel blockers and angiotensin receptor blockers. These can be given to help prevent or minimize the occurrences of Raynaud's phenomenon. Tetracycline can be given for diarrhea that can occur as a result of bacterial growth in the GI tract, again, due to the slowing of the movement of the GI tract, especially if we're talking diffuse scleroderma. Proton pump inhibitors and H2 antagonists can be given for the esophageal problems because dysphagia and heartburn will become a problem with the sclerosing of the esophagus. And then psychological support is one of the last things to mention here. Scleroderma does tend to develop rather rapidly over a period of just a few months. And because it develops so quickly and limits the patient's movement in such a rapid progression due to the hardening of the skin structures, it can be necessary for the patient to change jobs, to maybe not be able to carry out their activities of daily living as they once were. So psychological support is also very important. One last note that I will make about scleroderma is that with the limited cutaneous form, it only affects the skin, and therefore it generally does not interfere with the individual's lifespan. However, with diffuse scleroderma, which is, much less common, much fewer cases are the diffuse scleroderma. This can shorten the lifespan of the individual because not only does it cause hardening of the skin, but it also causes hardening and sclerosing of those internal organs. And as you can imagine, if it affects the lungs or the heart or even the GI tract, all of these structures would slow and it would lead to additional complications, ultimately shortening the lifespan of that individual.